do it. So it's hard to study. It's not the same. You can't just count bleeds because it's different. But I think they're open to this. I know I've talked to Pharma, and they likely will have a study coming out looking at factor treatment in non-severe hemophilia and include females. And also Genentech's Haven 6 study looking at Hemlibra included women as well with mild deficiency. So, let's start off with a case here. 34-year-old mother is about to have a baby. Ultrasound confirms it's female. A father has severe hemophilia, and the previous male child did not have hemophilia, and we don't know what the mother's status is. The presumption is that she doesn't have hemophilia in the family. So the two common scenarios that we see in this family, the male has hemophilia, so all of the daughters will have it. They're called obligate carriers. If there's one that doesn't have it, that means that's not his genetic daughter. That means you need to have a conversation with the mom about who the father is. And on the other flip side, when the mother's a carrier, that means there's a 50-50 chance. So if your daughters have a 50-50 chance, and it's a 50-50 chance every single time. If you've had 7 girls that are carriers, that doesn't mean anything. It's 50-50 every time. It doesn't change the odds by if you've had 25 girls with our carriers, it doesn't matter. So there's the obligate carriers. So this is a situation, the daughter of a male, mother of a male with hemophilia, and another male relative. And then a mother, if you have 2 sons, if you have 1 son, it's considered likely, but if you have 2 sons, that's obvious that you have, that you're a carrier. And so there's a lot of these mother of a male and no family history. So a lot of women fit in this category. And there's various programs available that you can get genetic testing. I know Pharma has a program right now that's available for testing, particularly if you just had a son with hemophilia. And so it's much more complicated than just the male and female. And so it's called heterozygosity. So what happens is in females, you have 2 X chromosomes. One of them has to inactivate. You only need one. So women have extraneous amount of DNA they don't need. And so one of them has to inactivate. And so you hope that the inactivation is random. So if it's random, that means the variant factor 8 gene or factor 9 gene would inactivate. And sometimes, and then the one that's normal would inactivate sometimes. And so you should end up with 40 to 60% levels. But for some reason, some people skew where they inactivate their normal factor 8 or 9 much more, and they end up with skewed inactivation. So if any of the women on this call have levels of 30, 40%, this is probably what you have. You have skewed inactivation. You could be one of these people. Maybe you met somebody when you were at camp, and so now you have 2 variants. And so that's very possible. And you may see that oftentimes 2 of the exact same variants. That's really unusual. If you have 2 different variants, that's like a girl that met somebody at hemophilia camp and decided to marry a guy with hemophilia, and she's a carrier. You're likely going to have 2 different variants, but 45% of severe hemophilia A is intron 21. And so you could have one of those variants together. So you could have one be skewed, have 2 different of the same variants or 2 different variants, and that would give the girl severe disease. And then there's Hemi Zygosity. So if you have Turner syndrome, which we've had a couple of patients in the past, you only have 1 X chromosome and you don't have the other one. And so this is not uncommon. You see this sometimes. Most of the time we diagnose this at birth. It has the distinct features that are diagnosed at birth. But it's something that's we do see as hemizygous patients. So in this situation,
I'm sorry, if you have Turner's disease, do you have hemophilia? I mean, are they always connected?
Whatever. Well, if you inherit, so if you get the variant X chromosome, then you have hemophilia. So if you inherit a moderate defect, then you're gonna have moderate. If you inherit a severe, you'll have severe. And that's in contrast to heterozygotes, which is much more common. 2 X chromosomes, you inherit 1 affected gene and then 1 normal gene. And then it kind of, it depends on the person. It skews one way or the other. So you could skew. A lot of women not on this call, but that are at home not having any bleeding, they could skew and inactivate the variant gene, and have levels of 150% and never bleed. And so there are people that skew the other way as well. They're probably less likely to go to meetings and be involved, so you may not know as many of those. But this one is XO. We've seen this. We've had a few patients in our clinic over the years. So if you have a severe mutation, you get severe hemophilia. So all the female children will be carriers because his father has hemophilia. Unless there's concern for Turner syndrome, it isn't necessary to do testing until 6 to 12 months of age. Certainly, there's a chance you could have very mild deficiency. That is very unlikely to cause any significant bleeding in the first 6 to 12 months. It's very difficult to get blood on young children. And oftentimes we have to repeat the testing. And so we don't like to get into this pattern unless it's really necessary to test right away, because you're going to have to test again. And so I don't like to do it unless I know it's a Turner syndrome or there's significant bleeding, of course. And, the delivery method, it's usually it's okay to be vaginal. It's definitely a little controversial. I'm not going to push anybody to do C-section unless the first child had intracranial hemorrhage. And so, again, deferring testing unless it's Turner syndrome, then you should test early. So what about bleeding prevention? Well, this is an old study showing that carriers from a postal survey in Austria were more likely to bleed with small wounds, with dental extractions, and with operations. And the majority, and this group had levels of low as 5% and as high as 219%. And so certainly this was probably the big study back in 2008 or 6, I can't remember, in which they really were able to demonstrate significant bleeding. And so, one of the things that's really difficult is that just like in mild von Willebrands, the levels are not very good predictors of bleeding. If you have less than 1%, you're going to bleed. That's not very hard to figure out. 5%, you're going to bleed. But if you have a level of 35 or 40 or 45, it's much more difficult to predict bleeding in that population. And that just hasn't been shown in any of these. This is from that Japanese manga on graphic novels on hemophilia carriers. It's kind of goofy, but it's kind of cute. So I just always include it. So when I was at Vanderbilt, we tried to go out and prove that there definitely is a bleeding tendency. We found the bleeding scores higher, menstrual scores higher, and we got almost identical data as Dr. Paula James and Peter Seigan. So I feel like it's pretty good. We actually presented my data 10 minutes before Dr. James did at a meeting. I didn't know what she was going to present. And I told her, thank God we had the same data, because they probably would have believed you more than me, because she's been around a lot longer. So recently there's this paper on carriers, and I wrote a chapter on hemophilia carriers in the textbook for hemophilia. So you can be happy that the textbook of hemophilia now officially has a chapter on carriers for the first time. So that's been written. I don't know when it's going to be published, maybe by the end of the year. But, when you look at bleeding risk, anytime it's on the other side of this line, that means there's an increased bleeding tendency. So they analyzed it: dental extractions, surgeries, deliveries. The joint bleed is where there's been some ambiguity and it hasn't been clear. Heavy menstrual bleeding as well. It's very common amongst women that don't have a bleeding disorder. Like 30-40% of women that don't have a bleeding disorder have terrible periods. And then nosebleeds is not very predictive. If you've ever been in the South, everybody has nosebleeds down here. And certainly majority don't have a bleeding disorder. So the only thing I've been able to figure out for carriers is when you look at women that have hemophilia or carriers, and you look here, when you try to give them DDAVP, they don't get their levels that high. So this is the change at the peak. Normal women, you give them a whiff of DDAVP and their levels go sky high. And when you sustain it at 4 hours, it stays low as well. So one change in one means it basically is the same after 4 hours. And so a lot of women didn't have a great response. To be honest, there's a little bit of data on this. And my theory is that if you're a carrier or a woman with mild disease and you respond really well to DDAVP, you're probably less likely to bleed than a person that doesn't respond. The only problem with this theory is it doesn't explain any bleeding in hemophilia B, because factor IX doesn't go up with stress. But we'll try to figure this out. We published this paper about 3 years ago. We had all the carriers here and all the controls were in Canada. They wouldn't let me give DDAVP to normal women in Atlanta. So we had to go to Canada to find them. So how do we manage, mitigate and manage hemarthrosis? In our data set, it's somewhere between 10 to 15% of carriers and women with mild hemophilia had a joint bleed. The problem with this and trying to study this is the majority of women have had less than 3 to 4 in their lifetime in most of the surveys. So it's really hard to do a study like a severe male in which they have joint bleeds all the time. And so you have to run studies over many years, which are very difficult to do. So we have to figure out a better way of studying this. It can't be the same way as we do in males. And we did a range of motion study. So this is normal women in their range of motion. We all lose our range of motion over time. And you can see here over time, it goes down from when you're young, you're very hypermobile. And then over time, you lose it just naturally. But what we found was carriers with normal levels, women with mild, moderate, and severe, their range of motion went down faster. And so the most interesting was the mild and the normals that were significantly different. And so we were able to get this study published with a lot of arm twisting with the CDC. But I think in the end, they made the right decision to allow us to publish this data from, and this was actually the UDC. So it was set up only for men, but centers sent data on women and they couldn't reject it. So it ended up accepting it. I only stumbled on it because I just saw, I was like, hey, there's like hundreds of women in here. Like, what are these women? And they said, oh, well, we got this data. We included it. We just never did anything with it. So thankfully they had to write it in. We had to throw out like a couple of hundred women because we didn't know if they were 8 or 9 deficient. So we would have had even more data. We've been trying to do various different studies. This was a data that I presented last year, multi-center review, and these were in women with mild hemophilia and women that were carriers. And we wanted to document the bleeding based on their chart review. And they had significant bleeding. Joint bleeds were reported. Most of them only reported 1 or 2 joint bleeds their entire life, but it's in the location where you expect it to be, elbows, knees. For the most part, that's where you expect it to be. And a lot of traumatic bleeds as expected in a bleeding disorder population. So this paper was published. We tried to do claims data sets, but they're not documented well. And so we published how we couldn't do it very well. It was a Bayer project. And so we tried to do our best on that. So it's been really hard. It's not for a lack of trying. We've done lots and lots of different studies. This one was published by Christina Haley, I think, who's giving you a talk next week or the next time you guys have a talk on women with bleeding disorders. And we were able to demonstrate that joint bleeding, the rate was about 10% in A and about 9% in B. And this is from the Athens data set. We were able to show that there were patients that had reported joint bleeds. We still have data that we have to report out. Obviously, COVID has made everything more difficult for research. Staffing has been like a nightmare. And so we should have some of this data by the middle of the year. I think we have a meeting coming up in a few weeks where we look at more of this data. Another great paper from Jan Ostermark, a Swedish guy, one of my colleagues, and Mehdi Uzuli published a really nice paper. They have really good data in the Swedish carriers and the Swedish women with hemophilia. And so they're able to go back and look and show the total number of cases here. You can see 213 were defined as factor 9 or 8 deficient, 326 were unknown. So they were able to get this data. And so in this study, they were able to show, you can see the distribution here. On average, people had levels of 50%. So this was my theory years ago, and they actually showed that exact normal distribution graph. So it actually turned out to be right. And if you had levels less than 40%, you were 2 to 3 times more likely to have joint bleeding and have diagnostic codes related to joint problems, and 10 times more likely to have a joint surgery later in your life. And so we really, this was a nice paper done by a lot of really good Swedish researchers. So hopefully more of these will come out. I think they're looking for some Danish data as well. And so one of the things that we want to talk about is like the non-severe hemophilia. I think the way that companies really focus on women is basically having studies that focus on non-severe hemophilia. So if you look at males, non-severe hemophilia A is about 50%. 10% of males with mild hemophilia A are on factor prophylaxis, as you can see in this graph here. That's the peak, 10% before they transition to adults. And if you look at moderates, 52% are on prophylaxis. So certainly we should be able to do studies in mild and moderate disease, including men and women. And it does get complicated. So everyone says, well, why aren't these studies being done? Well, we don't have the problem with in women inclusion in studies is if they have to have toxicity data, because if a woman gets pregnant during the study and gets, a factor product, we all know it's probably fine. But in studies, you have to have that safety and tox data for fetal exposure. And so that's where it gets really complicated. So it's more complicated than just excluding women completely. It's just because it's more difficult to do. Believe me, when I'm working on one of these new products, these new drugs, they don't have any toxicity data, so we couldn't do a study in women. So it was a little frustrating. And those are really hard to do right now because a lot of the primate labs are very busy, and it takes a long time to do those studies. Many of those studies take like $1 million to do a primate study. So they're very difficult. So when you look at management of hemophilia A, B carriers, and specifically those with levels less than 60%, so those with mild disease, there's no reason you can't give DDAVP for particularly those with mild reduction. It should be something to consider. On the dosing, and you can play around with the dosing. Some people can get away with one spray. I know that stimate is very difficult to find right now. It's still technically not available, but I know there's some other people trying to make some biosimilars out there. I know Stack Pharma and some people are giving it sub-Q, but certainly you can give factor. There's data to support this, guidelines to support this. And so when you come up to testing of these carriers in women with hemophilia, well, when do you send it? That's a tough question. So certainly before the first period, before any procedure, and then following a significant bleeding episode. And what should you send? Well, in hemophilia B carriers, until you know what the levels are, you should send it twice. It should be a one-stage assay. When somebody says order a factor 9, that's what they're talking about, one stage. Somebody says order a factor 8, you should order a chromogenic and a one stage. That should help. Sometimes certain mutations will give you discrepancies in which the chromogenic may be lower, and that may be more accurate. We use chromogenic assays when companies do studies for new drugs, and so there's no reason not to use it. Genetic testing is tough. Everybody said we should just do genetic testing, but it is important that we understand consent. When you're talking about doing genetic testing in young children that have not given their consent to do this testing. And so I think it's reasonable to do it in young children with counseling involved, and certainly should be sent at least by teenage years. But many countries like England and Canada, they feel very strongly about doing genetic testing if it's not going to change anything, because if your level is normal, you're going to do the same as you did if you did the genetic testing. So, and there are negative consequences for doing this stuff early without the consent of the young teenage girl. So we just have to be cognizant of that. That's all. And then consider treatment if levels are less than 60%. I see people ordering inhibitor testing. It's really, really uncommon to have an inhibitor unless you have moderate or severe disease. There really is almost no reason to send it on mild deficiency unless all of a sudden your levels are lower and you have a lot more bleeding. So there really isn't any data to support routine inhibitor testing because, you develop inhibitors because you don't produce the protein. When you're a woman, you produce the protein so your body can recognize it and doesn't see it as a foreign substance. So they've been reported, but we're talking about less than a handful. So on the testing, this woman had a PTT that was prolonged. Her chromogenic 8 was 30%, and her one stage was 45%. So by either measure, she's got mild hemophilia, but certainly we may want to dose her a little bit higher since one of her levels is lower. We did von Willebrand studies as well, just because there was some questionable history of that as well. So I think this is the last case. A 7-year-old needs a tonsillectomy. This situation has come up multiple times. And if you look at the labs here, the levels are in the mild hemophilia range. So people will call me and say, well, what would you do? And I would say, well, what would you do for a male with mild hemophilia? Do that. It's not that complicated. And so how do you prevent bleeding? And I think it's really interesting if you're on the von Willebrand session, von Willebrand factor levels in the very mild reduction range was not shown to be predictive of bleeding with tonsillectomies. It was a huge study done in Wisconsin, got thousands of kids involved. Great study done by Dr. Flood and the late Joan Gill, but it's more complicated than just the level being slightly low. Definitely tranexamic acid should be used heavily with tonsillectomies, and there's no reason not to consider it's very, very safe. And consider DDAVP if you are mildly reduced with A, and giving small doses of factor IX products as well, particularly if your levels are less than 40 or 50%. You may want to consider one big dose in the beginning. Typically, I don't give much more after that, but one big dose with a lot of Amicar tranexamic acid. So what about, we always talk about what would you do for the women? What would you do with the males? Shouldn't be that complicated. The only thing you may want to consider is if the woman's on birth control, you have to be a little careful. I know, there's a lot of discussions about calling everybody hemophilia, but we have to be very careful as you get older. If somebody's got risk factors like smoking or their factor VIII levels are elevated, you're at a higher risk for blood clots, and we certainly don't want to induce it with giving a factor infusion. So we need to be a little bit more careful, particularly if you have normal levels. But antifibrinolytics are very, very safe. It should be used very liberally. Every tonsillectomy should be used. And it should be used for like 10 days, like a long period of time. There's good data to show if you don't do that long enough, there's bleeding. And then high dose DDAVP is useful typically right before. You could give it a few days later. It's such a difficult drug to tolerate. I don't like to give it more than once. I feel like it works pretty well with once. And you start to get into major side effects if you use it more than twice. And then factor VIII replacement should be considered, or factor IX replacement, particularly if they can't get DDAVP or if they have factor IX deficiency. So that's reasonable. This patient got sub-Q DDAVP. They're just old enough to get it. You need to give it a little bit longer since it's sub-Q, and then pre and post antifibrinolytics, and they did fine. And there's one more case, I guess. 15-year-old with heavy menstrual bleeding. You can see here that on the comic, they're talking about this as well. Her one stage is 30 to 40%, and her chromogenics a little bit lower, but again, in the mild deficiency range. Had really bad, really bad periods. Got agestin, didn't like it. Got combined oral contraceptives, had breakthrough bleeding. And so, then we start to move into other options that we should be considering. Heavy menstrual bleeding is super common. This is the number of carriers that had it. But look here, 40% of our normal women had it too. So, and I worked them all up. They didn't have a bleeding disorder. So one thing that happens in young girls that is unrelated to hemophilia is anovulatory bleeding. So the way that we like to think about it is like when you're born, your nervous system is terrible. Your GI tract is terrible. Babies can't eat food right away. They're not coordinated. So just like that, the coordination of your menstrual cycle is not very good for the first year. It's usually very chaotic, skips lots of different months. And certainly other things can contribute to it, stress on the body, things like that. And what happens is you get incomplete shedding, and that happens over multiple cycles. You skip it a couple cycles, and then you have like a mega period. And that's very common with teenage girls with and without bleeding disorders. We had a couple hundred girls went to our emergency room for heavy periods last year in Atlanta, and none of them were hemophilia carriers. And about 10 to 15 ended up having von Willebrands, but the rest were without a bleeding disorder. So this is a huge problem across the board. You can use oral contraceptives. They're very effective in about 50 to 75% of the girls. We have one girl with moderate hemophilia, and she's been on birth controls for 6 years with like almost no period. And so it works in some patients. It doesn't work on everybody, but it's something to consider. And sometimes it takes a couple of different ones to try out to get it to work. And you have to find a good GYN that's experienced with managing that. And so heavy menstrual bleeding has lots of different options: tranexamic acid, birth control pills. There's a nice study that's going to come out from Angela Wine looking at the safety, because pharmacists often will tell us they're not safe to put together. I usually just ignore it and do it anyway because it's fine. We've done it for many years. We're trying to get data on it because it's clearly a safe option, particularly in a bleeding population. We don't need to worry about it. So in this little girl, it's got all these symptoms listed here. Is there an intervention? Well, it's really not clear that factor can reduce this. We've done this in a few patients, had some results, certainly seems to work okay in von Willebrand's, doesn't always work in hemophilia. And it is difficult. It's very difficult to do a study. It's surprising the number of people when we've had studies with women that didn't know how to stick, or the daughters couldn't stick. It became very difficult. There is an ongoing von Willebrand study right now. We tried to do a carrier one, and it just was really difficult to find people to participate. And so I'm hoping in the future, one of the companies will take it on and try again. But obviously things like IUDs are very good. If you go see a doctor or a nurse practitioner, they're very likely to have an IUD. It's the most commonly used form of birth control or menstrual control in working women. And so it certainly is an option to consider. It doesn't work on everybody, but it does work in some. If it doesn't work, you take it out and you don't do it anymore. So it's not that, it's actually fairly simple to take out. So now the controversial part, the nomenclature. You saw the normal distribution curve. Non-carriers typically have around 100% and carriers around 50%. And it's always very controversial. And so we went out and put this paper out. So I'm a senior author now, so I'm trying to encourage some younger authors to write too. So that's why Karen Van Galen, I think she's Dutch, wrote this paper. But we had to get international approval for this. And this is what we came up with. I would have liked it to have been 50%, but internationally they use 40%. And so if you have levels in the mild, moderate, and severe range, you should just be called hemophilia. There are women, we need to acknowledge there are women that have no bleeding or are asymptomatic carriers. And then there are ones that have levels of like 70, 80%, but have some bleeding. And we want to convey that symptomatic carrier term. It's like, people use the wrong term to characterize people, but I wanted to take this back. This paper just got published last year. And this is actually, I got two screens going here, so I'm looking over here because it's a little small for me over here, but this is going to come out in WFH, so don't put this out quite yet. It's a state-of-the-art paper for a WFH thing that we wrote with Dr. Scholzberg and Dr. Wyans. And so I wanted to be more clear about everything, that these carriers include heterozygotes, hemizygotes, skewed heterozygotes, compound heterozygotes. We want to stratify by severity and then stratify by bleeding type here. And we really want to emphasize, we still want to consider antifibrinolytics in this population and focus on factor and DDAVP and Amicar and tranexamic acid in this population. And so, it's a living document. I tried to explain how we came up with this. There were people that were very adamant about certain things that I couldn't get past them. And so, there's always compromise. It's a good first step. Hopefully, we'll keep moving this forward in the future. It's really nice if you go online. I'm not involved in this, but there's a Principles of Care for Women with Bleeding Disorders run by EHOD. That meeting is like a couple of weeks from now. And a lot of good providers that are involved in this, Dr. Lavin and Rezan Kadir, a lot of good providers. And Dr. Van Galen, I think, was also involved. So it's worth checking out online. I think if you look it up on YouTube, you can find some of this online. So it's not just on a US movement. They're also looking at it as well on the European side. So that's it for us. And we did have snow last week. I know Steve probably had a little bit more than me, but we did have a full inch here. So she probably had maybe 4 or 5 more inches than us, but we had some snow. So
We had about
So
7
much.
inches in South Carolina.
yeah, you got a little bit more than us. So thankfully,
We got
thankfully it was
stuck.
short lived.
We got stuck in North Dakota because Delta didn't have crews to bring us home, and it was negative 40 with wind chill. So I don't feel sorry for anybody. It was horrible.
Yeah, I don't know how people play football up in that kind of weather. It's crazy. They play like this now. It's like insane.
So I have a question. I know we've discussed it before, so I won't get into whether reasons why some of the bees should not fluctuate their levels, but they do. And again, we know it could be testing, it could be labs, whatever.
It's probably a lot of lab. It's probably a lot of lab variation. There's a lot of issues with lab stuff. So if you get 4 levels and 2 of them are about the same, that's probably what you should go with. You have one that's
okay. That's what I was wondering, because I've had 2 in the 30s and then a couple that were 50 and one that was 60. So I'm like, I don't really know what my base level would be.
It's probably somewhere in the middle. It's probably somewhere in that 40 to 50% range. So if you have one that's a lot lower, that means that it may have been an incompleted filled tube, or it may have got heat damage from travel in the mail and they didn't freeze it right. And you can get falsely low levels. And a lot of these private labs aren't going to reject samples because they don't, then you don't get paid for it. So yeah, that's why it makes sense to repeat it on sort of semi-regular basis. Just to see, and maybe it goes up slightly over time. It's not going to go up 30 to 40% over time. That's the Factor 9 just doesn't do that. So
okay, thank
Can I ask a question?
Sure, go ahead.
What are your thoughts about microbleeds? I'm about 30% AHF, but I'm 70 years old. Is there such a thing as microbleeds?
Yeah, I mean, I think there probably is, but your range is in the mild hemophilia range. And so you have macro bleeds too. So, not just the micro bleeds. And you have to think about it. Remember that study we showed of the Swedish women over time? Like, I think at your age, you have an accumulation of bleeding events that have led to some of the stuff that's happening now. And so even with, so if you take men with your levels, they're going to have damaged joints by the time they're 60 to 70 years old. That's a fact. They may say they're fine, but you'll see them limping around in the NHF meetings or HFA meetings. And you say, okay, well, you definitely have something. And so you definitely probably have an accumulation of bleeding events over time. I wouldn't say they're just microbleeds. I think they were just bleeds.
Well, is that why I have so much osteoarthritis now?
Well, I mean, that's always hard to separate out too, because that's always a difficulty in men. As well, like separating out osteoarthritis and what's arthritic pain related to this. MRIs often can separate them out a little bit. Often they can see that if they ever have to do surgery, like a replacement, then they can look in there and they can visually see. But obviously, you don't want people just opening up your knees and ankles just to look. But MRIs can usually see if there's old blood that's deposited in the joints. And unless you've had like multiple motor vehicle accidents, it won't look like that. Like athletes, like you took a football player, their ankles and knees, unless they were, unless it like broke their ankle or something like that, it's not going to have blood in their ankles. So it's going to look different when they have osteoarthritis from, just from overuse. So
And
MRIs can be helpful.
But it's difficult to know when to treat.
Well, the problem with people with mild deficiency or on the borderline is that we don't have any data. Like if you have a bleed like once or twice a year, it's hard to prove that factor twice a week is going to prevent that. You'd have to have a study for multiple years to show a difference in a study. That's where it gets really complicated. So
Okay, thank you.
And so yeah, it gets really complicated on these kind of things. But the companies are more willing than they were before to do studies in non-severe hemophilia. I personally feel like if you're a company that mostly makes factor, that's what you should be doing. That should be your group of people that you're taking care of. And, Hemlibra stuff is going to be mostly for severe and some moderates or people with inhibitors. And it makes sense to consider, doing good studies for non-severe hemophilia. So, and then it would include women. So it would be a good study. Can MRIs, one question in here is, can MRIs show old blood in the space? So yeah, you can actually see what's called hemosiderin deposits. The carriers that had normal levels on my Vanderbilt study had evidence of old blood in their joints. Not all of them, but a few of them did. They had subchondral cysts. They had some classic findings of mild hemophilia. You would see in a mild male when they turned 40 or 50. So certainly you've seen some of that. We did see that. So
can I ask a question?
Sure.
I know it's probably like too specific. I'll give you the scenario and try to make my question broad. So my daughter is, but she is a distant relative. So I know some family history. And so she tested, her factor eight levels were, were at 30, and
Okay.
7 and her factor 13 were low during that test too. So they said it's for sure an error. So when they repeated it,
Well, how old was she when they tested it?
6.
Okay. All right. Yeah, it's probably a lab error. If you're a baby, it could have been real, but if they're all 3 are low, it's probably some kind of lab error.
Right. So they repeated it, and factor 8 was still 30. Factor 7 was borderline low. And so they diagnosed her with hemophilia A.
Okay.
Her has 3 brothers that are all half siblings and in different families. They've all been
Sure.
adopted people. So her brother was tested to see if he was a carrier for hemophilia or had hemophilia or low factor 8, and his tests were normal. So those doctors, I'm in Alaska, he's in Boston.
Sure.
Those doctors, no, we don't think my daughter has hemophilia. They thought she had, they said you should rule out von Willebrand's 2N.
Yeah,
So
type 2N von Willebrand's type 2N/type 1 would be something I would rule out. And you can do the testing in Wisconsin. You can send the binding assay to Wisconsin.
Well, she had genetic testing for both factor 8 and von Willebrand's, and it showed, I think, no variants of there was, I think, some sort of mutations, but not of known significance. So
Okay.
her doctor here says her treatment would still be the same at a level of 30, factor 8, 30.
Well, it would be different because if you have type 2N von Willebrand's, it's not exactly the same because there's a defect in it. So you want to provide some VWF as well.
Okay.
And so this is the situation where a plasma derived factor may be the better option because it gives you a little bit of both. The type 2, and if they did actual type 2N genetic testing and they didn't find it, it's probably not there. Because we basically have probably described all the type 2N variants. I had one patient, we have a few at our center. The N stands for Normandy, and it's a very rare variant. There are people that are carriers of type 2N, and they can have levels of factor 8 of 50, 60%. Typically, the factor 8 isn't below 50% unless you have another variant for von Willebrand's. You see what I'm saying? Because it's a recessive disorder. So you can either be type 2N, and then have very low levels, or you can have type 1/type 2N, which is much more common, just by rolling the dice. That means either family members would have both be carriers of type 2N. And so it can happen, but that means you have to find these rare people and just happen to get married and have kids. So if they didn't find a type 2N variant on that gene when they did type 2N testing, it doesn't exist. The other thing they can do is a binding assay. If that binding assay is normal, it's not type 2N von Willebrand's, period. It's just not going to be. So there is a specific assay where Veronica, Dr. Flood, is if you just type in type 2N von Willebrand's, and I think it's called Versity now, it's available, and it really should give you the answer if it's that or not. It shouldn't be oh, we don't think it is. It's a pretty much a done deal. I'll post the service in the chat here.
Okay. Yeah. Because they were saying, well, we're just going to stick with the diagnosis of mild hemophilia A, but I just want older, she should have further so she
Well,
knows if
she should definitely, as you get older, the testing gets better and better. There's a small portion of patients that they don't find the variant, like 5-10%, but we know they have it. So they may be one of these ones where it's hard to find. Remember, everything isn't a deletion or duplicate, isn't a deletion. Sometimes it's these like funky things that are hard to pick up on the testing. But as in the next 5 or 6 years, we're probably going to find all these things. So,
okay, thanks.
so yeah, so they should stay on this. But if they did type 2N binding and it's negative, it's not type 2N, period.
Okay.
Yeah, because that's where the defect is the binding between VWF and factor VIII.
Okay.
That's why it's important, because if it's type 2N and you gave factor VIII, the level will go up temporarily and then go right back down, because the VWF is the defect. So you got to fix the VWF. That's why it's important to make the right diagnosis.
Okay. Yeah, we have factor. She hasn't needed it yet. All of her injuries were pre-diagnosed.
Yeah. Well, it's also important because DDAVP doesn't work in type 2N either. So that's why it's really important to know the difference. So, but if they're being seen, so you're associated with Boston, not the one in Seattle.
I'm in Alaska, so I think the Alaska clinic consults with Seattle. Her brother was in Boston. Doctors called up here and said you should.
All right. Well, if they said that in Seattle, then they're probably right. So Dr. Rebecca Cruz Jarez and Dr. Jill Johnson are pretty good. So I would trust them.
Okay. Thanks.
Yeah.
Robert, did you see the question about in one of your earlier slides in this talk, it showed only 10% of women responded adequately to DDAVP?
Well, it wasn't about a response to DDAVP. We use DDAVP as a evaluation of a stress. So we wanted to come up with a way to stress women, physiologic stress, and we didn't know how to do that. There's one study where you could do like put people on a bicycle and do it. And so there are a number of women that respond to this. There are some that did not respond. I personally don't like DDAVP that much. That's just my personal bias, because I think it has a ton of side effects. I think that's why it's a struggle to bring it back, because it just has so many side effects. And so it's just very convenient for minor procedures, because you can do the sniff, the intranasal. So that's the only reason. So we use it as a way to evaluate for stress. It still would have worked for minor procedures, but we were looking for like sky high things. And some women have like insanely high responses. And for me, those are probably the ones that don't bleed, because that means when your body is stressed, your body can defend yourself and get the levels up. And if you're one of those people that can't get the levels up, then you're probably the ones that are going to bleed.
Do we have any other questions, ladies? What was your question? Are you still here? It looks like my hemo just had a vein stripping in his legs and several egg-sized varicose veins taken out. Could that have been caused from previous bleeds?
Varicose veins, probably not. I wouldn't say that's definitely related to that. It's something that happens as you get older, unfortunately. So, but it's not something that's been linked to that. I've never seen any data on varicose veins and hemophilia or von Willebrand's. So.
Any other questions, ladies? Wow.
I had one I put in chat.
Oh, I'm sorry. I missed
Did
it.
you miss it?
But I was wondering if there's ever going to be a study for, I know you mentioned like childbearing age where you can't get an accurate for carriers. I'm a symptomatic carrier, but I'm past childbearing age.
Sure.
Well, I could probably do it.
Anyway. That's the wanting to do it age, yes.
Yeah. But like when said, maybe for a different age range.
Yeah.
I don't know.
Well, we've been talking to the companies about doing these studies. I think they're listening and trying to do these kind of studies. Like I recently talked to Octapharma, for example, and they were interested in this idea. I know Novo Nordisk is sort of kicking this idea around as well about non-severe hemophilia studies. And that way you can include men, women, anybody that wants to be in the study, doesn't matter. It's just whatever your levels are. It's the measurement that's the hardest part. So severe hemophilia, super easy to do a study on. Everything is annualized bleed rates, super easy to measure, hard outcome. And then as you get to milder patients, the outcomes becomes difficult to measure. And so the FDA gets a little bit nervous about it. They want to see definite benefit, when they talk about drugs. And so that's where it gets complicated, trying to prove it in a scientific manner. So it is more complicated, and that's why it's been difficult. That's why it hasn't been done. It will get done eventually, though. So.
Thank you.
I have a question for you, Dr. Sidonio.
Sure.
So I kept having reoccurring bleeds in my ankle, just one ankle. And it was really very frequent just recently because we moved. So I was up and down the stairs. I'm going in every probably 10 and 14 days, getting infused, and they don't have meniscus here. So I'm just measuring it and taking pictures. But so now I went back to the clinic that normally sees me with an ortho guy who doesn't necessarily seem to understand exactly what he's doing in hemophilia world, but it was a referral from my HTC. But I'm scared because he wants to go in for surgery. And how many should I go and get a second opinion? Because I was going to go fly out to see Jill Johnson just before I went ahead and let any surgery be done on my ankle.
Well,
I feel like it's such a risk, with all this.
You want to, and people like talk about meniscus all the time, but you can just do an X-ray, and if there's blood in the ankle, you'll see it. If there's any
X-ray
fluid,
showed nothing, but
yeah.
MRI did.
Okay, so sometimes that may be older stuff that's starting to affect you as you're getting older, and not like it's like you're having like chronic stuff that's showing up. Because if it's an acute bleed with blood in the ankle, you can ultrasound somebody. You don't need a fancy meniscus thing. So when people have this, I just they come to the emergency room. I just tell them to do an ultrasound, and there's no blood there. It's probably not an acute bleed. And so you definitely want to have an orthopedic surgeon that's associated with your clinic, that works with them. We have one that's been here for a while. It's been doing surgeries for like 20, 30 years. They have some in various places that have done it.
It makes me
in our
nervous
population.
because he was looking up while I'm at the first appointment. He took that time to look up hemophilia B and the relevance for it with being mild, how often it might turn up with a woman, telling me it couldn't be a bleed at all. But now they've come around to say I have loose ligament there and they want to do surgery. And hopefully that will stop the bleeding. Because when I do treat for it, if that's that can be diagnostic too. And when I treat, I certainly feel better. Even leaving the ER, I'm feeling better within 3 hours. I'm usually there 3 to 6 hours.
But there could be something that's triggering it too, that, there could be something where there is something surgical to fix. You certainly want to make sure you're being treated with the procedure as well. And we've had patients, lots of males have had surgeries over time. And sometimes there's something, they've done a synovectomy or something else to try to limit the bleeding. And that may be an option as well. We don't do the radionuclide synovectomies anymore. I think there may be a few people who have done it. So, but I think that's kind of fallen out of fashion because of the risk. So, yeah.
Okay, guys, we have.
So it's not typical.
Go ahead.
I'm sorry. Is it not typical to go get a second opinion then? I'm just worried.
No, I mean, it's certainly
about
worthwhile getting a second opinion from an orthopod, get them to take a look at it. And it may be really short visit. They may say, yeah, I totally agree with this. Makes sense to do this. So,
okay. It's a lot of time and money to get that second opinion. So I just.
That's the problem with it. It's not like there's
right thing.
They don't have these docs everywhere. They're limited how many there are. So, yeah.
So guys, we have about 5 minutes left, and I do see that someone else that hadn't had a chance yet to ask a question. Actually, there are two. I don't know if we'll be able to get them in. It's 5 minutes. One was, my son has hemo B with inhibitors. His doctor said the mutation we carry is a deletion in the DNA, and the inhibitor goes along with this type of mutation. So does that mean if I use factor 9, I could end up having an inhibitor?
So no. So in women, inhibitors are very, very uncommon. Because remember, when you have the males, they only have the X and the Y. And so you don't see inhibitors as much in hemophilia B because they make this what's called cross-reactive material. They're more likely to make a tiny bit of factor. And in hemophilia A, when they have these large deletions, your body doesn't make any. And then it gets really confused when you infuse it. If you're a carrier, you have some factor in your body. Your body has been exposed to factor forever. And so the chances of it getting an inhibitor in a woman are very, very, very low. Unless you're Turner syndrome, which wouldn't have been this situation, obviously. But it's very, very unlikely. There's like less than a handful that have gotten it documented. So
Thank you.
in the
And then-
women. So yes.
Okay.
Thank you.
One last question. I have a question about Hemlibra and birth
Yeah.
control. My severe A daughter just started instead of Advate.
Yep.
EOD, she switched at a new HTC, and before I had time to research, she is very independent, 22-year-old.
Sure. Yeah. I mean, well, that's part of the problem. We don't have good data on birth control in this. I personally would not have an issue with using birth control and on this. Certainly, I would be advising about, good lifestyle habits, not smoking cigarettes, things like that, because that certainly can put you at a higher risk. There are women on the Haven 6 study that were, I'm sure, on birth control. So we should be able to get some of that data. I think when you particularly have a severe bleeding disorder, I think the risk is so low when you're talking about clots now. It's mostly the ones I worry about are the ones that are very mild or normal. And then you're giving factor products and birth control. That's when I worry that there's a risk for clots. So I think the chances are extremely low.
Great. And then one quick one, if we can, and then we'll let you go. Sherry had a
Sure.
great question. Dr. Luck presented Tuesday night for HFA
Yeah.
on joint replacement. Did you see it? Can you read it?
I can see the question here, but yeah, Dr. Luck has been around, man, he's been around forever. So
she's wondering if women will be studied too.
yeah, I mean, they're not like formal studies. He's got like a special clinic and he's accumulated experience over time. I think the problem is, he was doing a lot of these in the HIV era. So he's talking a lot about infection risks. And, with better therapies, we're going to see a lot less joint surgeries. Our orthopedic surgeon used to come every other month. And now he only comes like twice a year because we just don't have those as much in the non-inhibitor patients. Usually people that just aren't doing their infusions. It's usually just that. Somebody that's supposed to be on it, but they're not doing it. So we don't see as much of this. So hopefully it will get better. So.
And that's a tough one. Pain control. What is it you want to know about pain control? Poor doctor.
Yeah. I mean, that's definitely something it's tough, but a lot of the adult providers have been managing pain in men with hemophilia for many, many decades. It's obviously changed a lot. It can't just be, opiates like it used to be, now it has to be lots of different things. There's lots of different things people can try. There's massage therapy. I know people have hemophilia. You can still consider things like acupuncture. Obviously, if you have any bleeding issues, you could take some Amicar when you do it. But there's a lot of good data on acupuncture as well.
Dry needling has been really
Yeah.
helpful for me.
Yeah, you got to be careful if your levels are a little bit lower than that. That's the
Yeah.
only thing. So,
Yeah.
and then, there's some good physical therapists, rolling with the foam rollers. These things that seem silly, a lot of times they actually are very, very useful with yoga and rolling with the foam rollers.
All right. Well, thank you all for being with us. Dr. Sidonio, as always, thank you so much. We'll see you, we hope, on the 17th of February, Reproductive Health and Women with Bleeding Disorders. And that is with Dr. Christina Haley, who Dr. Sidonio just referred to, and Karen Gibbons. So thank you all for being with us tonight. We really appreciate it. And thank you, Dr. Sidonio.
Oh, thanks. Everybody have a good night.
Thank
Thank you.
Have a good
Thank
evening.
you. Good night.
Good night.